and it will be posted on the BC Renal website. Next slide. So gratefully, I'd like to acknowledge on this beautiful almost March morning that all of us, many of us on this call are on the land of the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, and the Métis community of the Lower Mainland region. Wherever you are in the province, I think, as always, we reflect on the things that we can learn from the land and the people, and what we can commit to giving back to both. Next slide. So Province-Wide Rounds is a collaboration between UBC and BC Renal, and proudly acknowledging all of our industry sponsors who, in a very open and educational way, support our ability to deliver these rounds, and all of the health authorities that are here today. So thank you for that. The next slide is really a pleasure to be able to introduce Dr. Mina Matsuda-Abedini. Mina is a pediatric nephrologist at BC Children's Hospital and a clinical associate professor of pediatrics in the Faculty of Medicine at UBC. She's a McGill University grad and finished her specialty training in pediatrics at the Montreal Children's Hospital, and then did a fellowship in pediatric nephrology at the University of California, San Francisco. She started her career actually here in BC in 2005, and then she went to the Division of Nephrology at the Hospital for Sick Kids in Toronto for 10 years, and then saw the light and came back to BC in 2022. Dr. Matsuda-Abedini's research focuses on improving the care of children and adolescents with chronic kidney disease and those with a kidney transplant, including their successful transition of care to adult specialists. She's also an investigator in the CanSolve CKD network, and happy to welcome you, Mina, and looking forward to hearing your thoughts and ideas about the CKD journey. So I'll hand it over to you. And thanks everyone for coming.
Thank you so much, Adira. I'm just gonna share my screen.
Perfect.
Great. So good morning, and thank you so much for the kind introduction, Adira, and for inviting me to speak to you this morning on the CKD journey across the life course, Pediatric Patients Perspective. So what I hope to do this morning and first half of the talk is to share with you an understanding of the symptom burden of CKD from children's perspective and its impact on their life participation. And in the second half, we're going to shift gears and focus on the need for a structured transition to adult care for childhood onset CKD and kidney transplant that really should continue in young adult kidney care, and discuss some of the elements of a successful transition pathway. And this is where I'm really hoping that either at the end of this talk or offline, the audience would share some of their own thoughts and novel ideas on how we can do this better. So the CKD journey in childhood can begin as early as in utero. So what I'm sharing with you here is the ultrasound of a fetus, a male fetus with a very dilated bladder. And in panel A, you're looking at the classic keyhole sign of posterior urethral valve, which is obstruction of the bladder neck, and then bilaterally dilated ureters with renal dysplasia. So this is PUV, as you know, is one of the CACUTs, that's congenital anomalies of the kidney and urinary tract, which is the most common cause of chronic kidney disease in children. So as you can imagine, when we first encounter this patient, we're actually meeting with the parents, the expectant couple who have been told on the antenatal ultrasound that their fetus has chronic kidney disease. And as this baby grows up, our engagement with the patient changes from being entirely parent-directed for infants to include the whole family unit in childhood, And then later on, we gradually shift towards the young person to ensure successful transition to adult model of delivery of care. And all children and adolescents with CKD and dialysis and kidney transplant are cared for at BC Children's Hospital in our province. But when they reach the age of 18, 19, we are transitioning their care all across the province to many different care teams. And that's one of the challenges in transition of care. And throughout their CKD care at BC Children's, like many of you, were paying attention to things like nephroprotection, kidney function, and managing all the complications of CKD like anemia, nutrition and growth, and bone health. But in this, as part of the Standardized Outcomes in Nephrology initiative, the SONG initiative, the study looked at generating a consensus-based priority list of critically important outcomes to be reported in all trials in children with CKD. So 2 rounds of Delphi survey were done. In the first round, there were 557 participants. In the second round, 312 participants, representing 48 countries. So this is a global initiative. And what I want to point out here is that the participants were healthcare providers, family members, in addition to patients ages 8 to 21 years living with CKD. And the 2 gray lines on these illustrations show the outcomes that are identified as most important to healthcare providers and families. And as expected, there are things like mortality, kidney function, cardiovascular health. But the orange line shows the priority identified by the patients living with CKD ages 8 to 21 years of ages 8 to 21. And what I want to point out here is that they put life participation and things like ability to travel, spend time with family and friends, mobility, and academic performance above the other outcomes. So life participation was really highlighted as a very important outcome for children and adolescents living with CKD. But then this leads to a question of, well, how do we best measure that when delivering care? So back in Canada, our patient and parent partners in research and the pediatric nephrology community also identified this as a research priority. The question being, what are the most relevant symptoms for children and adolescents with CKD and on dialysis, and how can they most reliably be measured? Thinking that the symptom burden is what leads to an impact on life participation. So the first thing we did is we looked in the literature to see if there is already an existing patient-reported outcome measure that we can use to validate in pediatric CKD. What we found were either generic PROs that were developed to be relevant across different chronic illnesses and patient populations, but we found that any one generic instrument lacked the specificity needed to robustly capture the pediatric patient's experience as they progress through different stages of CKD. Then we looked at disease-specific PROMs, and many of you at this webinar are familiar with ESAS Renal. That's the Edmonton Symptoms Assessment System revised that is used in many adult dialysis units in Canada. And Sarah Davison, who is one of our co-investigators and was very involved in the ESAS Renal, pointed out that that 10-point Likert scale may be challenging for children to use for assessment. And our pediatric co-investigators also felt that looking at the literature, that the language of ESAS Renal would be challenging for some of our younger children. And it was felt that it was not the best tool to try and use for our patient population. And the pediatric PROMs that exist were largely developed in the oncology patients and also lacked the specificity for CKD. So then we were left with having to actually develop a PRO for children and adolescents with CKD and dialysis and then validate it. And that's how the ProKit project came about. ProKit stands for Patient-Reported Outcome Measures in Children with Chronic Kidney Disease. So pre-pandemic, or just, yeah, right before the pandemic, was the phase 1 of the study where we developed this tool. And then in the last couple of years, we validated this tool for ages 8 to 18 years. And we're in the process of finishing validation for a younger age group, which is a modified ProKit and a French version in Quebec. And at the same time, we have moved on to implementing ProKit into clinical practice and will be evaluating the implementation. So the key things in developing this tool was that we wanted to capture a broad range of symptoms that included physical, cognitive, and emotional domains. And we wanted to include 2 symptom dimensions. So 2 of our co-investigators are from palliative care, one from palliative care nursing and another one a palliative care physician in pediatrics. And they pointed out that when they were developing the tool in oncology, they had noticed that there were children who would score their pain 4 out of 5, but would still get out of bed, go to school, and play with their friends. And there were other children who would score their pain 2 out of 5, but 2 out of 5 was severe enough that they couldn't get out of bed. And that's where they felt that it needs to have 2 different columns assessing the severity of a symptom and the impact on their life participation. And based on literature review, a 5-point scale was felt to be most appropriate for symptom dimension assessment in children. So in phase 1 of the study, we had Natasha Jawa was a research trainee with us who has gone on to do, right now doing a PhD at Queen's. She completed cognitive interviews of children ages 8 to 18 with CKD stage 2 to 5, including dialysis, as well as cognitive interviews of caregivers. These were open-ended questions followed by close-ended probing to assess symptom importance, understandability, and recall period. And in the end, we developed an easy-to-complete 14-item questionnaire that captures cognitive symptoms, emotional symptoms, and physical symptoms in children. This is what the tool looks like. So the language is very easy to understand for school-age children. And then the frequency is in the past week, how often did you have the symptom? And separately, in the past week, how much did the symptom bother you to assess the impact? And the 5-point Likert scale is a scale from not at all to always. And then for ease of understandability and interpretation of the symptom, each score is converted on a scale of 0 to 100. And what we found was the most common physical symptom reported by children with CKD and dialysis was fatigue, which is not surprising. The most common emotional symptom was feeling left out. And the most common cognitive symptom was inability to concentrate or focus, which is obviously very important for school-age children. Then in phase 2 of the study, we had to validate ProKit. So this was a national Canadian study involving 5 pediatric nephrology centers. We enrolled 100 patients ages 8 to 18 years, CKD stages 3 to 5, including those on dialysis. So median eGFR was 27.4 milliliters per minute, and just over a quarter of the patients were on dialysis. And we were able to show a strong internal consistency and strong correlation between ProKit and PedsQL, showing construct validity, which that enables us now to move ahead and use ProKit in clinical care. And when the paper came out, there was an attached editorial co-authored by a young adult patient who had developed CKD in childhood, as well as a parent of a patient with CKD. And they commented on the strength of the study being inclusion of input from patients and caregivers, and designing and vetting a much needed tool that's non-burdensome in terms of number of questions and the attention to age-appropriate phrasing. And on that note, our patient partners wanted us to, parent partners wanted us to modify this tool so that it can also be used in children as young as 5 in kindergarten. So for the 5 to 7-year-olds, we have modified the tool to a 3-point scale using emojis. And we have now validated this in this patient and this age group using cognitive interviews. And we're about to submit this for peer review. And we also have a French version that is currently being validated at 2 sites in Quebec, so that we have a French version for use as well. Going back to this slide that I showed earlier, where life participation was identified as a priority for outcome measurement in CKD trials, as a sub-study of this ProKid at the same time that we were administering the ProKid tool for validation, we had a simple 3-item life participation questionnaire where we asked the same patients in the past week, how much has your ability to participate in school been affected, your time with family and friends, and your ability to participate in hobbies or recreational activities. We have a fellow, research fellow with us, Dr. Karma Abu Qasim, who's doing her master's degree at UBC. And she recently analyzed this data on life participation by CKD stage. And as you can see here on the y-axis is the impact on life participation. And on the x-axis is the CKD stage. And as anticipated, impact on life participation is very little in earlier stages of CKD, stage 3 and 4, but it really starts going up in stage 5 pre-dialysis and in dialysis patients. And this finding was statistically significant. And as expected, when we look at quality of life, there's an inverse relationship between the impact on life participation score and quality of life. So your quality of life goes down as there is more impact on your life participation because of your CKD or dialysis. So what are some of the uses of, or what we hope are some of the uses of ProKid for children with CKD and dialysis? We're hoping that it can be incorporated into clinical care and research as a measure of patients' perspective of health versus disease in a quantitative way. And we hope that it improves patient-provider communication, which is very important in shared decision-making. And additionally, we're hoping that it can be a guide in clinical decisions regarding timing of initiation of kidney replacement therapy. We know from the IDEAL study, which was a large randomized trial in adults, that showed no benefit to early initiation of dialysis based on GFR alone, and that symptoms should guide this decision. And from a study that I'll share in the next slide, we know that there's currently significant practice variation regarding timing of dialysis initiation among Canadian pediatric nephrologists. And then hopefully having a tool like ProKid would allow us to evaluate efficacy of novel therapies that are developed for management of various CKD symptoms. So this was a Canadian study done a few years back, asking pediatric nephrologists about the criteria they use for initiation of dialysis in children. And there was considerable variability among different practitioners, meaning that some use GFR alone. There is a certain cutoff GFR at which they move ahead and start dialysis. Others, obviously use symptoms, ask about symptoms like fatigue, weight loss, nausea and other symptoms, but we don't really have a standardized way to quantify the symptom burden for patients. So the eGFR threshold that's used in clinical practice for dialysis initiation is quite varied among pediatric nephrologists, and there are many who would start dialysis at higher GFRs of 10, even in the category of 15 to 19. So it was this study that had highlighted that there's a knowledge gap regarding factors that should influence timing of kidney replacement therapy initiation, and that there's a need for standardized decision making. And in a bigger study that was published just a few years ago in JASN, looking at USRDS data of more than 15,000 children who had initiated dialysis between 1995 and 2015, as you can see on this graph, there appears to be a trend towards starting children on dialysis at a higher eGFR. So higher eGFR was defined as eGFR greater than 10, and lower eGFR as those with eGFR less than or equal to 10. And it's striking that between 1995 and 2015, which was the end of the analysis period, that the proportion of children with higher eGFR at dialysis initiation has doubled. And the trend has even continued after the adult IDEAL study was published. And this was true for both peritoneal dialysis, shown in the dotted red line, as well as hemodialysis in the black line. And these investigators showed that higher eGFR at dialysis initiation is not associated with a survival benefit. So in a separate paper by colleagues from England, they essentially said in the coming years that innovation in symptom assessment should enable us to balance the burden of symptoms attributable to CKD with the very real burden associated with dialysis therapy, and that patient-driven quality of life symptom assessments are likely to become key components of the dialysis initiation decision-making process. So we're really hoping that a tool like ProKid plays a role in this decision-making process. And this paper is just hot off the press. It was just published this week online in CJASN, looking at trends in timing of preemptive kidney transplantation in children, again, using the USRDS database. And as you can see here, in the left part is the living donor and the right part deceased donor, comparing 2006 to 2019. And here too, once again, we're seeing a trend towards a higher GFR at the time of preemptive kidney transplantation. So having a tool like ProKid should hopefully help us look at this additional measure of symptom burden as well as eGFR to see why these trends are happening, and is there a way for us to standardize our approach in this very important decision of initiating kidney replacement therapy. Now, using the learning health systems, we are moving very quickly from developing and validating this tool to moving it to implementation and moving it into clinical practice. So in this knowledge mobilization phase of the study, supported by Council of CKD, we have our research fellow, Dr. Karma Abu-Qasim, who I mentioned earlier, leading this implementation phase by conducting focus groups at different pediatric centers across Canada to identify barriers and facilitators to implementation at each site. And very quickly here at BC Children's, we have already implemented ProKid into clinical care in our CKD dialysis clinics. Same with Winnipeg, and other centers like Toronto and Hamilton and Calgary should be next to enroll this. We're also collaborating with CKD, which is a large study funded by NIH that looks at CKD, different CKD parameters like cardiovascular health, neurocognitive assessments in a prospective way as patients progress towards dialysis and transplant. And by having ProKid administered at each of the study visits, we should be able to see whether it's sensitive enough to pick up change in symptom burden over time. And we've been approached by other countries to have ProKid translated into different languages like Mandarin that will allow a more global use of the tool. We're going to shift gears a bit here and discuss the next part of the study, which is transition. And one of the many purposes of a tool like ProKid, we're hoping, is to give patients a voice in their clinical encounters and engage them more and more throughout adolescence in preparations for transition to adult care. In the KDIGO 2024 clinical practice guidelines for evaluation and management of CKD, transition was one of the areas of focus where it was highlighted that the whole process of transition needs to start early as ages 11 to 14 years. And we should be using checklists, which we do, to assess readiness that is developmentally appropriate, and then gradually prepare our patients for transfer of care to adults at the age of somewhere between their 18th and 19th birthday. What I want to highlight here is that transfer is just one point in time in that transition process. And really, the transition process needs to continue for young adults up to the age of 25, 26. Because as I will show you in the next couple of slides, emerging adulthood is really a period of high risk. And these emerging adults need to be seen more frequently than older adults at the same CKD stage. And it's important to include caregivers whenever needed with permission for patients at these visits. And in addition, in the KDIGO guidelines, they talk about joint pediatric adult clinics and allowing young people to visit the clinic before transfer, which is feasible in some places, but the geography of BC, where our CKD patients are transitioned to many different sites across the province, really doesn't allow realistically to have a joint pediatric and adult clinic. And in terms of visiting the adult site before transfer, this is actually something we do for our kidney transplant patients, who majority of whom have their care transitioned to St. Paul's Hospital, to Justin Gill and his transplant team, before later on going to a transplant center near home. So why do we really talk about transition being so important? In this study that was done just over a decade ago now by Susan Samuel, who is now part of our division at BC Children's Hospital, she looked at core data, so that's Canadian Organ Replacement Register, and linked it to CIHI, the Canadian Institute for Health Information Discharge Abstract Database, to identify patients who had started end-stage kidney care before 22 years of age. And what she was able to show in this study is that among the patients who transferred to adult care during the study period of 2001 to 2010, avoidable hospitalizations, which was defined as admissions to hospital for ambulatory care sensitive conditions, meaning that if they had a primary care to go to or an urgent clinic to go to, this hospital admission could have been avoided. And that hospitalization rate was highest during the period 2 to 4 years after transfer of care compared to their last year in pediatric care. And this was at the same time that the overall hospitalization rates were decreasing, suggesting that really those first couple of years or first few years after transfer of care these patients need a little bit more attention. And this holds true, very true for our kidney transplant patients. Many studies have highlighted the increased risk of poor graft outcomes during the transition or peri-transfer of care period. So in this very large data analysis of over 90,000 patients in USRDS who had their first transplant at the age of less than 40 years, Beth Foster and colleagues analyzed the data on graft failure rates per 100 person years versus age. And what they were able to show is that there is an increase in graft failure rate that starts at age 12, but it really peaks at 17 to 24 years of age and then declines thereafter. So the 17 to 24 years of age was labeled as a high risk age group. And the relationship between age and kidney graft failure risk is remarkably constant and shows the same pattern across races, sexes, primary kidney disease, insurance types, living donor versus deceased donor, and so forth, suggesting that we just need to pay more attention to this particular high-risk age group to improve health outcomes in this patient population. And one of the big risk factors that's been identified, which contributes to this increased risk of poor health outcomes, is poor adherence. And adherence to long-term therapy for chronic illnesses in high-income countries averages around 50%. And before we can find a solution to this, we need to identify what are the risk factors for poor adherence or suboptimal adherence in this patient population. And the World Health Organization identifies 5 big categories, and those are healthcare system issues, social and economic factors, condition and treatment-related factors, and patient-related factors. So to examine these one by one in our kidney population, the first one is patient-related factors. So we're working with adolescents and young adults. And we know that communication with this population is sometimes challenging, especially in this world of them being on their devices and often being on social media. It's very difficult sometimes to engage them in clinical encounters. So we need to think outside the box and find novel ways to communicate better with our patient population. So one of my pediatric cardiology colleagues actually is using an SMS platform called WellTel Health, which is a BC-based, Vancouver-based company, to use messaging to check in with heart transplant patients ages 12 to 19 between their clinic visits. So this is not only used to check in on patients, but also as a way to remind them of their upcoming tests or upcoming clinic appointments. And this is used as a tool for better communication with this patient population. And I know that at St. Paul's now, there is a transition group that is doing virtual workshops, for example, for youth as an opportunity to engage better, improve their engagement with their peers and care providers. The other thing we need to be reminded of is that gray matter maturation in neurodevelopment is not yet complete in many of our adolescents and young adults who are going through transition of care. In this prospective neuroimaging study of healthy children ages 4 to 21 who were scanned with MRIs every 2 years for a decade, investigators were able to show that there is a remarkable heterogeneity in the rate at which cortical gray matter matures. Parts of the brain associated with more basic functions matured early, and last region of the brain to mature is the prefrontal cortex. And the prefrontal cortex is involved in executive function, working memory, attention, and problem solving, which are all neurocognitive processes that are absolutely essential for adherence. So what does this mean in practical terms? This means that when adolescents and young adults are in our clinic, we can't just verbally tell them to do something and expect them to remember that when they walk out the door. That perhaps writing it down, putting it in an email, and if necessary, letting a parent or a care provider know about the change in their medication dose or in their treatment plan is a helpful thing that we can do to improve their adherence. And then additionally, studies have shown that children with CKD also struggle with their academic achievement. So in this CKD study, they were able to show using standardized psychometric assessments, they showed that low total academic achievement, and that's age-based standard score less than 90, was present in a third of the 319 patients in the study. And one of the reasons for low academic achievement that has been identified in a separate study by colleagues in Seattle is that many of children with CKD and dialysis miss a lot of school days. And chronic absenteeism was defined as missing 18 full days of school or more. And that happened in 21% of the children in this particular study. And the number one reason for missing school was doctor appointments and anything associated with their clinic appointments. So one of the things that many of us do is that we alternate whenever possible, especially for patients with milder stages of CKD. We use virtual visits in between their in-person visits to try and minimize the burden on families, particularly those who live outside of the Lower Mainland and have to take much time off to come to Vancouver. So these are some of the things that we can actively do to improve the adherence of patients as they go through this transition process. And then obviously the other big thing is condition and treatment related factors. We all know that patients with CKD and dialysis are prescribed numerous medications that they have to take. And this is where our renal pharmacists play a major role as part of our multidisciplinary team. We all know that the more pills patients have to take and the more frequent the dosing times during the day, that the rate of adherence goes down. So our renal pharmacists at every review, at every clinical encounter, look for ways to simplify the frequency whenever possible and educate our patients and families to use cues to remind them to take medications and to use dosettes, and if need be, blister pack have the medications blister packed to really attempt to improve their adherence in CKD clinics. And then there's health system and socioeconomic factors. So in terms of health systems, this has been looked at in one of the transplant studies that we did, where we looked at, are there any things we can do at the program level to improve adherence of patients? So for this particular study, there were 270 kidney, liver, and heart transplant recipients ages 14 to 25 years of age, with a median age of 20 years. And adherence was measured at baseline, 3 and 6 months. And what we were interested in are program level factors that's associated with adherence. And what the study showed is that the odds of adherence were 12% higher for each additional routine blood test that was prescribed per year, and 15% higher for each 5-minute increment in average amount of time the nurse spent with a patient at clinic visits. So what these findings suggest is that appropriate staffing, so allowing more nurse time per patient and maintaining more frequent routine blood monitoring for transplant patients, which is monthly, and not spreading it out to every 2 months or 3 months, for all high-risk youth, high-risk young adult transplant patients may have a meaningful impact on adherence and therefore their outcome. So this is really relevant for those young adults who have just had their care transferred to an adult program in those first 4 to 5 years that they're particularly high risk. So these are practical things that we can advocate for and put into practice that, based on these studies, have shown to make a difference. And one additional thing that has been shown to make a difference is having a structured, purposeful, multidisciplinary transition program. And the goals of a transition program is really to build and support self-management and self-advocacy skills in a neurocognitively appropriate way. And then engage the receiver team, so our adult colleagues, identifying champions who are invested in this young adult population and able to adapt adult care to a young adult focused clinic, and then guiding patients and families through this transition process, or in other words, system navigation. I often use the analogy of a driver's license with our families. When a 16-year-old gets their learner's permit, we can't expect them the next day to confidently sit in the driver's seat and drive off on the highway confidently. It takes time, and it takes different 16-year-olds a different period of time to get to the point of being new drivers and then really confident drivers of a car. And similarly, for our patients, at the beginning, when we start the transition process, we really visit by visit go through these checklists and give them the time they need to develop that self-management and self-advocacy skills. But really, by the time they're ready for transfer, they're really still new drivers when they arrive in your adult clinics. And they need a little bit of extra time and support to become completely independent and confident. So in this transition multidisciplinary team, we have a nephrologist, a nurse, a pharmacist, dietitian, social worker. And what I want to point out is that these are not separate clinics, but we have incorporated this into their regular CKD or transplant clinic, meaning that we've just cohorted them by age group so that in addition to their regular CKD care, we're also focusing on elements of transition and making sure that they're getting ready for eventual transfer of care. And in the transplant program, we have partnered with St. Paul's so that we have regular meetings with the St. Paul's team to discuss patients who are transitioning there. And this has been very helpful because in that initial period as young adults between the ages of 18 to 25, most of our kidney transplant patients are going to St. Paul's. And then from there, when they're felt to be completely ready and confidently managing their transplant, they go to a transplant program closer to home. For CKD, that has been a little bit more challenging because it's really not realistic for patients who are approaching, let's say, dialysis or transplant to all have to go to one center in the Lower Mainland, but rather they're going to a CKD clinic that's closest to where they reside. There are many different tools that can be used as a checklist to assess transition readiness. And this particular one is available online for transplant patients, where it is based on whether they're in early adolescence, so ages 11 to 13, middle adolescence 14 to 16, and 17 to older being late adolescence. And at each visit, there are similar tools to use for CKD and other chronic illnesses, where essentially you're looking at their disease, the patient's disease knowledge, medications, adherence, risk-taking behavior, and managing their health and self-advocacy. And the idea is that the multidisciplinary, so different members like the clinic nurse, dietitian, pharmacist, social worker, really focus on different elements at each visit and identify any gaps that need to be worked on more or addressed between the different transition visits. And until they're then really the team feels that they're ready to have their care transferred to an adult program. And one may ask, well, do these transition clinics make a difference? Years ago, when I was first at BC Children's and we started a transition program, we looked at this and compared the outcome, the hard composite outcome of death and graft loss in our patients who had been transferred prior to establishing a transition clinic to the cohort after having a dedicated transition program. And we were able to show that there was a significant difference in outcomes, where before having a structured transition program, there had been 3 deaths and 7 graft losses, all of which had occurred in the first 2 years after transfer of care. And this is actually similar to many other studies that have been done in Europe and elsewhere, where really that first few years after transfer are the most high risk with poor outcomes. And we were able to show that transition clinic had made a difference. Now, I know that this is not realistic that the death or graft loss would be 0. The follow-up period for this at the time of this analysis was quite short. It was only 3 years. But nevertheless, studies have shown that any kind of a structured transition program does make a difference in clinical outcomes of patients. So in summary, I hope that I have shared with you now that youth living with CKD and kidney transplant really do prioritize life participation, and we need to find better ways to include this as part of their clinical care and in our research studies looking at outcomes. And we're hoping that programs like ProKid give patients a voice in this in the shared decision making of their care. Patients 17 to 24 years of age are particularly high risk, and they benefit from having a specialized transition clinic. And transition process does not end with transfer of care and really should continue beyond transfer in a young adult clinic. So again, remembering that there are new drivers and they would benefit from extra support. And that neurodevelopment is ongoing when most patients are transferred, and many have not yet mastered all the tasks related to self-management and self-advocacy. And adult programs should encourage continued parental and caregiver support and involvement whenever that's needed. And I want to end with a thank you slide, particularly my ProKid co-PI, Allison Dart, who's a pediatric nephrologist in Winnipeg, all the co-investigators and collaborators, and really all the patient and families who generously partner with us in our research, in our and in clinics, and of course all the funders, Cancel CKD, and many different foundations who have supported the studies I've presented this morning. And with that, I'm going to stop and see if there are any questions. Thank you.
That's great, Mina. Thank you. If you stop sharing, then we'll be able to ask. Thank you for presenting. It's always wonderful to hear all the work that's going on, especially in Canada. And thanks for your leadership, both in the transition care and the ProKid space. Evidence-informed care is always a lot better than we feel like this is the right thing to do. And I think you've demonstrated that really very, very terrifically. I'm just going to see if there are some things in the chat. Not yet, but there's a Q&A for you. Do you know of any other interdisciplinary transition teams within nephrology in BC outside of the St. Paul's post-transplant transition clinic? Is that a gap that needs to be addressed in our province in native CKD patients? So I think that's very much what you wanted to talk about, right, Mina? Is
Yes,
like
that's very much what I
help
wanted to talk
visualize that.
about. And whether it's here or offline, I am looking for really novel ideas to do this better for our CKD patients. Because, like I said, for the kidney transplant program, it's working very well where our patients, majority of our patients are going to St. Paul's first. And then from there, they're going to a program closer to home. Once again, it's that 18 to 25 years of age, and not everybody has the same timeline in terms of when they are. Again, it's like new drivers, like it takes time. Some people, some 18-year-olds are very good drivers behind in that driver's seat, and others take a bit longer. And it's just being aware of it. And what's helpful with having that one team is that we're able to have regular meetings once we have a few patients who are transitioning, and it's a two-way communication and it allows our patients to have a meet and greet visit with St. Paul's, and then they come back to us before we complete that transition. So it really it's comforting for patients who have been, let's say, at BC Children's for 18 years. And it's not just the adolescent, I have to say, it's also the caregiver who needs to let go. And
Yeah.
it's very hard. Sometimes our parents get very emotional because they have that relationship that they've developed from when their baby was born till 18. And now all of a sudden, it's something completely new to them. And no matter how much reassurance we provide that, we have great adult colleagues, you're going to be very well taken care of. But it's just so much is happening at age 18 that, some of our adolescents are, graduating from high school, going off to university. Just so many other milestones are happening concurrently that it's a very challenging time. And for
All the more
CK, yeah.
to say all the more reason to start it earlier before there's huge life changes. But I think, what you were alluding to and what Justin's saying, and then Sunit's comment, I think Sunit's saying there's many patients with CKD have a systemic or genetic disorder. What are other areas doing with transition? And then a personal experience that she had with very poor coordination of care, like someone with osteogenesis imperfecta.
Yeah.
So I think that one of the things that Mina and I were talking about before this started is, perhaps within each health authority identifying a champion for this and then working up, because on the one hand it doesn't happen that often, but there are enough children that need some kind, and it's not a random thing. And then I think we've had a couple of, not, I won't say false starts, but like well-intentioned beginnings, but not a way to operationalize this. So maybe, offline we can talk with the medical directors and yourself of each of the health authorities, identify some champions, and then, learn from what has worked with the transplanting and look at how that might work with the CKD world, and also get some numbers behind it so that we can actually implement it. I don't know, you were saying there's a complex care transition clinic at St. Paul's for other chronic conditions, and I don't know very much about that. I think Monica might know more about it, but I'm not, I don't know whether in the first instance we try and boil the ocean and put all these chronic diseases together, or we have a very specific problem in kidney disease and we're trying to manage that, and then we amalgamate with others, because I think sometimes it's harder to do the big than it is to do sort of our own contained thing. But interested in your
Yeah,
thoughts.
and some of it, honestly, is out of, I mean, Justin Gill, who's here, will tell you that, sometimes it's as simple as, a patient with a G tube and kidney transplant. So the kidney transplant transition part, went very smoothly, but it took me a year to figure out how to identify an adult program to manage the patient's G tube and G tube feeds. So it's really, and different models have been tried in different provinces. For example, I know Alberta recently just published their results on a transition navigator. So essentially somebody at a provincial level to help patients navigate the adult system for all the different chronic illnesses. But what's tricky is that there isn't one thing that can work for all chronic illnesses.
Right.
There are some things that are unique to a patient population, like, as we've seen in CKD transplant dialysis needs are very different. And there are some shared elements, but really it needs to be individualized and to the disease, to the population, and that's where and the resources for each program are different. A patient with epilepsy is not the same as diabetes, CF, or kidney. And as you pointed out, Adira, the numbers may be small per year, but cumulatively,
Yeah.
and this is the way medicine is going. The complexities are increasing, um, and many patients. And again, having BC Children's in one site, all the subspecialists and all the programs are under one like in one place. But when it comes to adults, it's a little bit more challenging to keep it all in one
Yeah.
unit.
No, and there's two really good comments in the chat as well. So
Mhm.
one is the psychological connection as an important thing because in a way this is like a divorce, and yet we don't actually a divorce from your first team and a new marriage with the second team, and we don't really think about we haven't perhaps articulated it that way and how that kind of counseling could be done. And then there's Erin saying that there's a Scotiabank Youth Transition Program which is trying to set up some general supports for all. And I think you make a good point. Like there are some generic things, but perfect. Like I'm a believer in like generic for basic, but you need the specialty touch, as you were saying, because there are unique differences. And I think we also often forget the neurocognitive issue, which I think we downplay because you don't have a good way to measure neurocognitive development or maturity the way that we would like to, and that unless there are tools. But if that would be something really, really interesting to try and
Yeah,
look.
so in one of the slides that I showed, the neurocognitive thing is so in a study setting, they used standardized psychometric assessments to look at the CKD population. And what's fascinating is that really these are things that you cannot pick up in your clinical encounter. These patients can present very well, and you have no idea that they have any deficits until they have a formal assessment done by a psychometrist and psychologist. And only then, and the deficit that's identified in patients with CKD is executive function, which is not something you can pick up in a clinic. And we all know that it's not realistic to send everybody for a psychometric assessment psychologist. So just being aware that there is a possibility of problem with executive function. And what that means is getting from point A to B. So telling them, okay, increase your enalapril from 5 milligrams to 10 milligrams, they walk out that door and they're not going to remember. So there really needs to be that, what I call the external brain, that sometimes, putting in an email, like in our case, our nurses may put in an email to the parent, but perhaps that young adult can put it in their device, letting, again, whether blister packing is realistic or putting it on a piece of paper, like, or in their phone, but essentially needs to be written down. And if ideally at the beginning, having that, the parent in the passenger seat of the driver, just having somebody else supervising, double checking is helpful. But we know that these deficits do exist, and for some, last longer than others.
Yeah, no, listen, I think we could talk about this for a long,
Yes.
long time and it's the bottom of the hour. So I want to thank you very much for not just the work you do, but also for stimulating the conversation. I'm going to suggest and propose that we probably develop a small working group and have a little bit of a brainstorming session, provincially to see how to actualize some of the amazing work that you're doing, but also to formalize some of it. So,
That
thank
would be great. Thank you.
I'm sure that there's a lot of interest. You had over 40 people, actually almost 50 people on the call. So I think there's a ton of interest around the province. So stay tuned and we'll look forward to working more with you and your colleagues.
And thank you so much. And please, please do email me offline if you have ideas, suggestions. I'm always looking for ways to improve this. And so thank you so much.
Very welcome. Thank you to you. Great.
Thank
Bye,
you.
everybody.